webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website, autism.org.
Dr. Emily Casanova is an assistant professor in the neuroscience program in the Department of Psychological Sciences at Loyola University in New Orleans. Throughout her training and early career, Dr. Casanova's research has been focused on the study of autism from various perspectives, including investigation of its overlap with hereditary connective tissue disorders such as Ehlers-Danlos Syndromes and Fragile X premutation, as well as the investigation of major effects of autism susceptibility genes and their evolution. Rosie Head recently graduated from the University of Texas at Austin, majoring in human development and family sciences with a concentration in early childhood. During early 2023, she was a clinical intern at the Johnson Center for Child Health and Development in Austin, Texas. These webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website at autism.org. And now I'm going to turn this over to Emily and Rosie.
All righty. Thank you so much for that introduction. So I'm just going to kind of briefly talk about a little about the overlap that we're finding between Ehlers-Danlos syndromes, hypermobility spectrum disorders, and autism. Research is still kind of early, so kind of bear with us. I think this is going to be an area that's going to slowly become more popular. I know it's certainly an area that the stakeholder community is really, clamoring for more research in, and I think researchers are going to slowly start getting that point. So I think we're going to slowly see more and more research in this area because I think it's probably affecting a significant minority of individuals on the spectrum, as well as their families who may or may not be on the spectrum themselves. So just kind of first off, I want to talk a little bit about what are the Ehlers-Danlos syndromes. I'm going to assume that most of you are more familiar with the autism side of things rather than the Ehlers-Danlos connective tissue side of things. So just a little bit of background. The Ehlers-Danlos syndromes, or EDS, these are a type of hereditary connective tissue disorders. Connective tissue is kind of like the glue that holds your body together. A lot of times these conditions involve some sort of generalized joint hypermobility, so people may be hyperflexible. You also may see elasticity of the skin, as the gentleman in the upper right-hand picture is displaying, to a very extreme degree in his case, as well as some kind of tissue fragility. We also see a lot of chronic musculoskeletal pain and instability, as well as a variety of secondary issues that I know Rosie's going to talk a little bit more about, like immune disorders and autonomic disorders and endocrine or hormone disorders. Finally, I also want to introduce you to a term called hypermobility spectrum disorders. This is kind of a newer diagnostic entity that is meant to cover a lot of individuals who have an Ehlers-Danlos-like phenotype or presentation, but they really they're not meeting the full criteria. And instead, people with HSD, you're seeing more of the chronic musculoskeletal pain and instability, as well as the hypermobility. But maybe not some of the other elements that are part of the EDS criteria. But these conditions do seem to occur in the same families. So you may see somebody with hypermobile EDS, and you may see other individuals in the same family who have a hypermobility spectrum disorder. It can really vary a little bit, but it suggests that they're probably a spectrum condition as well, although we're still kind of doing more research on that. Now, big question is there a relationship between autism and EDS HSD? Unfortunately, to date, there have really been no major clinical studies that have looked at the co-occurrence rate of those two spectrum conditions. There was a large retrospective study that was done a number of years ago, I believe out of Sweden, and that found, and that was basically just doing a chart review. So it was looking at a large number of people and looking at their medical records and seeing how many of them had these co-occurring diagnoses of autism and Ehlers-Danlos. And it seemed that about 3% of folks within that database had the comorbid diagnoses. Now, I do want to point out, though, that both autism and Ehlers-Danlos are definitely underdiagnosed. Autism, it's maybe not quite as much of a problem here in the United States nowadays, but certainly I think there's still an diagnosis rate over in Europe, which is where that study would have been coming out of. And then certainly Ehlers-Danlos is underdiagnosed in general. So it probably suggests that that 3% comorbidity rate was probably fairly low, and we would expect it to be a little higher. Some early preliminary studies suggest it may run between 10 to 15%. We also see that certainly autistic women tend to go underdiagnosed, and we're seeing a major gender bias in terms of Ehlers-Danlos being diagnosed in women. It's more prominent in women, or at least it's diagnosed more frequently in women. And so probably they're not getting autism diagnoses quite as frequently as well. So we're probably missing quite a few individuals. There have also been a number of case studies, but those are the major things that we've seen in the research literature on the overlap between autism and Ehlers-Danlos. I do want to just kind of point out when I attended the International Society for Autism Research, or INSAR, back in 2019, the topic of the relationship between EDS, HSD, and autism was a major research priority for the stakeholder community. So that is really suggesting that the research is not currently reflecting the need within the autism community at the moment. Now, as far as some preliminary evidence, our laboratory started off doing a few survey studies early on. One survey study, we surveyed over 700 individuals and found that there's some suggestion that Ehlers-Danlos or hypermobility spectrum disorder in the mothers may be a significant susceptibility factor for autism in the child. So if you can kind of take a look at this little weird violin plot, this little red and blue violins here. The one on the right, or the one on the left, is representing mothers who have autism. Okay, and then the one on the right is the one of mothers who have Ehlers-Danlos or hypermobility spectrum disorder. And this is basically showing the rates of autism in their children, the reported rates. And you can see that really there's no difference. So that suggests that that autism in, or Ehlers-Danlos in the moms is as much of a susceptibility factor potentially for autism in the kids as if that mother herself also had autism. So we're not really seeing a big difference between those two different spectrum conditions and susceptibility. We also see in moms who have EDS, HSD, and also have autistic children that they tend to report more immune-mediated symptoms. So they may actually be having higher rates of immune disorders. So there is the possibility, again, that the maternal immune system could be playing some role in autism susceptibility in the child. And that kind of harkens back to some a wide body of literature on autism in general, looking at maternal immune activation and susceptibility factors. So that's certainly feasible as well. And that's just one of the articles, just giving you an example of maternal immune activation that we see in autism in general. So as far as some of the work that I'm doing right now, I am actually studying Fragile X spectrum disorders, in part because, just to kind of give you a little preview, we have found an Ehlers-Danlos phenotype or presentation in females with the premutation, with the Fragile X premutation. And so since we already know what's going on genetically with these folks, this actually makes them a fairly good syndromic model of Ehlers-Danlos in a way. And because one of the problems with hypermobile Ehlers-Danlos, which is the most common form of Ehlers-Danlos and makes up probably about 80 to 90% of the entire Ehlers-Danlos patient community, we don't really have any good ideas in terms of what's going on genetically with these folks. It's probably a lot of different things, which is probably why we've not found it yet. And it's just not as simple as some of the more rare versions of Ehlers-Danlos. But in any case, these Fragile X spectrum disorders give us a really great opportunity to kind of understand what's going on to the connective tissue and what's happening to this. How is this resulting in this clinical phenotype while we already know what's going on at the genetic level? So that gives us kind of a leg up. So just as a little bit of background with some of the Fragile X spectrum disorders, just in case you're not already familiar with it, these are associated with mutations in a gene called FMR1. And this is responsible for two conditions. It's responsible for full-blown Fragile X syndrome, which probably more of you may be familiar with. And even some of your kids may have been tested for this at some point. This tends to be associated not only with autism, but also with intellectual disability, especially when it happens in boys. And so this is one of the major things that if you get genetic testing in autism, what they might try to rule out. But then we also have the Fragile X premutation, and I'll talk a little bit more about what is the difference between those. So in this gene, in the what we call the promoter region, which is just the region of the gene that basically tells it to turn on or off if it's going to be expressed or not, there's a long string of trinucleotide repeats. And by trinucleotide, we just mean 3 little nucleotides in a row that are repeated over and over and over again. So in this case, they have CGG trinucleotide repeats over and over and over again in the promoter region of this gene that tells this gene whether or not to be expressed. And so the majority of individuals, and I want to say this is totally normal for everyone. We all have this, at least a certain number of trinucleotide repeats in this gene. This is normally how this gene works. So the majority of individuals have trinucleotide repeats where the number falls in the range, usually between about 26 to 32 repeats. That's typical. But then if we see repeat numbers falling outside of that range, we may start seeing effects to how much protein that gene is ultimately able to produce. And so we see that between 55 and 200 repeats, which is much higher than the 26 to 32, that's what we call the premutation range. And these individuals were identified because they were at a higher risk for having kids with full-blown Fragile X syndrome. So these people with the premutation, they don't have Fragile X syndrome, but they have a related condition. It's usually more mild, especially in terms of the intellectual disability. They don't tend to have ID, but they may have other neurodevelopmental issues, and we'll talk a little bit more about the relationship to autism as well. But anyway, so we see this premutation range falling within about 55 to 200 repeats, and then anything 200 above is full-blown Fragile X syndrome. This falls on the X chromosome, so in boys, they only get one, which is usually why boys who have Fragile X syndrome tend to get intellectual disability as well. Whereas when it happens in girls, that's much more variable. And so there are certainly individuals with who have an IQ that falls within the normal range, and they are full-blown Fragile X. So it really can vary a little bit in terms of how severe it turns up in females. Now, the prevalence of Fragile X syndrome is about 1 in 2,400 to about 6,000 people, but the prevalence of the premutation is about 1 in 400 men and 1 in 200 women, which means that this is not a rare condition. This is common. You have undoubtedly met people with this condition, even if they themselves did not know that they had it. And even some of you in this audience probably may well have this, especially since we're all coming together because we're interested in autism, right? So that probably increases the likelihood that we're going to see a little more higher rates of the premutation within our population here. So I will say, unfortunately, the majority of individuals are not diagnosed. Most individuals only get diagnosed when they have a child with Fragile X syndrome. And the majority of people who have the premutation tend not to have Fragile X kids. So the majority of people go undiagnosed. Now, when we look at the premutation carriers, about 5 to 15% are on the autism spectrum. Now, when we see Fragile X syndrome, that's closer to about 50%. So it's much higher, but it is definitely significantly increased in the premutation carriers. And we also see a relationship between the number of repeats that those premutation carriers have and a relationship to autism symptoms. So for instance, things like theory of mind may get worse the higher number of repeats that across individuals. So in terms of connective tissue, there have been a number of reports and studies looking at joint hypermobility in Fragile X syndrome, so the full-blown syndrome, especially reports regarding hypermobility of the hands and the feet. Nothing more extensive really than that, but not much has been reported in terms of joint hypermobility and the premutation. So that's something that's kind of new that we're working on. So I am collaborating with some folks out at the Mind Institute as well as Greenwood Genetics, and we're investigating an Ehlers-Danlos phenotype or Ehlers-Danlos-like phenotype in women with Fragile X premutation. And so so far we are finding a number of cases that look like hypermobile EDS or generalized hypermobility spectrum disorder, which means that had they not already been diagnosed with that, they very well could have been diagnosed with Ehlers-Danlos. And so we think there's probably a portion of individuals on the Ehlers-Danlos spectrum that are probably unrecognized premutation carriers, especially given how frequently the premutation occurs in women. Remember, it's that 1 in 200. So I do want to say it's still kind of early. It's been slow going. COVID has kind of thrown a wrench in these works over the years. We're slow going, but we have collected a certain amount of data so far, and we are seeing a definite trend in the relationship between the number of trinucleotide repeats within that premutation range and susceptibility to the Ehlers-Danlos phenotype. And so right now, what we're seeing is the higher number of repeats, actually, there's a bit of a protective effect. And so individuals who have more of the Ehlers-Danlos, that connective tissue phenotype, they're more likely falling around that, 80 to 90 repeat range. Whereas individuals without that expression, that connective tissue phenotype, they're falling a little bit higher. So it's still early days. We don't know if this trend is going to continue to hold, but we shall see. But just to say that it will have significant clinical implications in terms of what is actually causing this tissue phenotype if these results continue to hold, because we do see more of a degenerative issue occurring around that low to mid repeat range that we see with some other Fragile X related issues like neurodegenerative disorders like FXTAS, which is the Fragile X associated tremor and ataxia syndrome, as well as FAX-POI, which is the premature ovarian insufficiency that occurs in premutation carriers right around that repeat range. So we'll see if that continues to hold and whether this might not be another one of those mid-repeat range risk factors for developing a variety of medical issues. So a little bit of a lesson from the premutation that we can apply then to Ehlers-Danlos. So overall, we tend to view Ehlers-Danlos as essentially collagen-based disorders. So collagen is a particular type of connective tissue protein, and it has been implicated in a number of the more rare versions of Ehlers-Danlos. So it does tend to be assumed that collagen is at kind of the foundational base of all of the Ehlers-Danlos syndromes. And so, right now, but with the hypermobile EDS, remember I said that we don't really have any identifiable genetic factors at the moment that have been widely recognized as risk factors for the most common version of EDS. So probably what we would expect to see is that very much like we see in autism, where it's obviously a very genetically complex group of conditions that have behavioral overlap with each other, but really on a family by family basis, there can be quite different causes. And so in general, we expect to see that, like in autism, we see that a minority of individuals have rare genetic variations that are largely responsible for their condition, such as Fragile X syndrome. But then the majority of individuals tend to have a more complicated genetic background. Maybe not always rare stuff that's easy to identify. Maybe be more like combinations of genetic variations that are maybe not completely uncommon in the broader population, but do end up being risk factors when you put enough of them together. And so that gets a lot more complicated. You may also see people in that larger group, that more complicated group, that also may be more responsive to environmental stressors or triggers. So you may actually see an issue with a trigger, for instance, an illness, some sort of immune trigger, et cetera. So I kind of expect Ehlers-Danlos to go a similar way, even though we're not quite there yet in terms of how we recognize what and define what EDS is. I'm of the ilk that wants to move it towards a more generalizable, complicated, complex kind of condition, very much like autism, whereas there's still a number of individuals in the traditional genetics community that would like it to be a much more strict definition. But we'll see. I don't think the patient population wants it to be quite so strict. But anyways, so why is this relevant? How is this relevant to autism? So FMRP is the protein that is ultimately produced from the FMR1 gene that's associated with the Fragile X spectrum disorders. And this protein is very strongly expressed in early brain development, especially in neural stem cells and precursor cells. And it helps basically to regulate a lot of different aspects of gene expression. So it's kind of a big hub for regulating a huge number of different other genes. And so it has a significant effect on brain development, as you would imagine. And so we also see that it has altered expression levels in what we call a fibroblast, which is the cell in the body that produces a lot of the connective tissue for the body. And so if you kind of mess them up, they may not produce connective tissue quite in the way that they were supposed to. So we may see this relationship between FMRP in the brain and FMRP in the fibroblasts that are producing connective tissue. So that may be how we see some of these neurodevelopmental conditions combined with some of these hereditary connective tissue disorders. And so that's one possibility. Also, too, we talked a little bit about immune disorders in people who have these hereditary connective tissue disorders. And there is the possibility that, especially if we've got an immune disorder that's occurring in a mother who is currently pregnant, that could also influence autism susceptibility in the developing embryo or fetus. And so it's possible there could be an indirect causal mechanism as well. So, or it could be a combination of any of those things. Biology is often not the simple answer, right? So it probably is something like that. So that's kind of how we're trying to pin this down and hopefully use these Fragile X spectrum disorders as kind of a syndromic model to study Ehlers-Danlos and the relationship to autism in a broader sense. So hopefully we'll be getting this published, this next series of studies published within a year or so. Again, as I said, it's been a little slow going. It can be difficult to recruit individuals with Fragile X premutation. I will say, if anyone listening to this is a female with Fragile X premutation and you're interested in taking part in one of our studies, please do feel free to email me and I can try and see if we can get you in, because most of you are not diagnosed, unfortunately. So as sometimes it can be hard to find folks from this population. And on top of it, a lot of people who are diagnosed with a premutation, they have kids with Fragile X syndrome. And let's face it, life gets busy and it can be hard to come in and spend an hour or two for a research study and not know what you're going to do with your child. So that can also be a challenge as well. So, but in any case, if you're interested, I can certainly share my email. You can also look up my blog, and I have my Gmail listed on my blog. My blog is Science Over a Cuppa, and you can certainly find me that way as well. And I'm always happy to answer any questions that you have if you don't happen to get a chance to ask your question today or think of something interesting later. So in any case, I want to thank my collaborators, the Hagermans over at the Mind Institute, as well as Louise Gain, who's now in New Orleans, where I'm at, and she used to work over at the Mind Institute, and she's been helping a little bit with recruitment, as well as my collaborator, Carrie Buchanan, and her team over at Greenwood Genetics Center. So thank you very much. And I don't know if we're doing questions now or if we're saving them towards the end, but either way, I'm here.
Yeah, I think that we'll save the questions until the very end.
Good. So let me stop share then. Okay, there. Perfect.
Okay. So my name is Rosie. Thank you, Dr. Casanova, for giving me a good baseline. I have both conditions. I was actually genetically tested 2020 and confirmed to have classical EDS, which is one of the more rare types, but it's one of them that has identifiable genes. So I was able to get a definitive answer. And I just want to talk to you a little bit about some of the shared symptoms that overlap. A lot of Dr. Casanova's work has touched on these, so you can always go and look up her papers for more info, more in-depth scientific explanations for everything. But yeah. So to start out, the nervous system is highly implicated in both conditions. Sorry, let me pull up my PowerPoint. So specifically across both conditions, ADHD has been found to be more common in both EDS and autism. I know a lot of people know about the connection between ADHD and autism, but it's not as well known with EDS. Other psychiatric disorders like anxiety, depression, eating disorders, bipolar disorder, these can all be linked to EDS and ASD. And it's important to note that things like anxiety and mood disorders are highly linked with the autonomic dysfunction that's seen across ASD and EDS, which I'll talk a little bit more about autonomic dysfunction later. And then seizure disorders, they are much more common in the autism community, especially for individuals with autism who have intellectual disabilities. They're still much more common in those with autism without intellectual disabilities than the general population, but it's at a lower frequency. And women with EDS are actually more likely to have seizures than the normal population. But it's important to note that a lot of the people who were polled as having seizures and EDS report them starting after some sort of head trauma, which could be related to things like fainting, different kinds of accidents from clumsiness, and just general joint laxity. So it's hard to say chicken or the egg with EDS and seizures. And then going to sensory and coordination issues, both conditions, you commonly see motor development delays. Like Emily said, I'm sure most of y'all are familiar with the autism side of things, so I'll kind of speak more towards the Ehlers-Danlos. But a lot of kids are seen as like overly clumsy, issues with fine and gross motor in terms of fine motor, like holding a pencil. I know a lot of young kids struggle with that with EDS just because of the finger hypermobility and the grip strength. But it's likely related to proprioceptive impairments that are seen in both. So a lot of people with EDS have, because of their joint laxity, have diminished proprioceptive awareness, which can lead to a lot of coordination issues. Going on, pain is very common across both conditions, especially in EDS. And both of them have actually been discovered to be linked with C fiber denervation, which is like small fiber, and it kind of leads to small fiber neuropathy. So in EDS, it's seen as more generalized hyperalgesia, so kind of all over pain, whereas in autism, it's more linked to those areas with higher concentrations of C fiber nerves. And in autism, it's more like, oh, like this certain area hurts. It's you push and like it's not a normal amount of pressure that would cause pain, but in these folks it does. And then EDS, it's just kind of more pain all over, tends to happen when your joints fall out. And then other sensory sensitivities, like I said, you all know about the sensory sensitivities in autism, but with EDS, a lot of people are unaware that there are still the same visual and auditory sensitivities, but it's more likely linked to the autonomic dysfunction that I talked about previously and we'll continue to talk about. And it's actually come out that cardiac function is believed to play a significant role in sensory processing. And in a lot of folks with EDS, cardiac function is not what it should be per se, whether that be through postural orthostatic tachycardia or orthostatic intolerance, different kinds of things, as well as aortic valve prolapses and things like that. So big to keep in mind. It's still kind of we're still kind of looking at it in terms of why these POTS and things like that can affect sensory integration and things like that. But it's an interesting link that I had not heard of before. So getting into autonomic dysfunction more broadly, we're all aware of like sensory dysregulation in autism, autonomic dysregulation, things like that, where stimming comes into play to kind of self-regulate. In EDS, it's seen a lot more broadly, I would say. In EDS, a lot of people have high resting sympathetic tone, and sympathetic is fight or flight, and parasympathetic is rest and digest commonly. So kind of always being in that fight or flight zone, which of course contributes a lot to heightened anxiety and things like that. And across both of them, blunted sympathetic reactivity to certain stimuli, especially like tilt table, orthostatic tests like that. And so in ASD, the common signs of autonomic dysfunction are high resting heart rate, larger pupils, and increased respiration rate. In EDS, it's more obvious. The high heart rate, hypotension, so POTS, you stand up and then pass out sometimes. Gastrointestinal dysfunction, and usually that has a lot to do with motility, like gut motility, so gastroparesis or chronic constipation, things like that. Bladder dysfunction, so frequency of urination, things like that, and temperature regulation difficulties. And then immune dysfunction, Emily kind of touched on that, so I'm not going to go into a lot of depth, but it's difficult to know in EDS if the immune disorders predispose people to EDS, like in periodontal EDS, which is one of the more rare forms of EDS, or if the chronic collagen dysfunction leads to chronic immune activation. And then you see things like mast cell activation, which is a common comorbid condition for people with EDS. And Emily did a much better job of explaining that than I would be able to. But the implications for immune dysfunction are pretty big in both, and still need to be researched. So then this project was kind of my capstone project for my undergraduate degree. And obviously this held a special place for me because I have EDS and I did not get diagnosed until I was 19 or 20. And it could have saved me a lot of pain and grief if people had known earlier and knew what to look for. It's really important to say that this isn't medical advice, and a lot of kids are just normally bendy. That you can look at a kid and see that, oh wow, like I can't imagine how their joints are doing that. But in EDS, it's usually a lot more extreme. So things like party tricks where they can lock their hands behind their back and bring them all the way forward, putting their legs behind their heads, things like that. I would recommend, if you have a child who does those, to tell them to stop, because you will end up with many joint surgeries and potentially life-threatening complications like thoracic outlet in your adulthood if you continue to do those. Found out the hard way. But so it's not just general kid flexibility, it's like the extreme end. You might hear them talk about being double jointed, like really frequent dislocations, but also more commonly subluxations. So like the joints not fully out, but it's not really in. So, kids have a funny way of saying things like that. But I always said my shoulder's really loose. Like it's kind of just hanging. And turns out it was just chronically subluxed. But joints to look out for specifically that are more common in childhood presentations would be the shoulders and elbows. So like my elbow goes the wrong way. It's part of the Baton criteria normally. And that's not a normal range of motion for even a child who is very flexible. And then other loose joints, hips, fingers especially come into play when it gets to school age and they're trying to figure out how to hold a pencil and accommodate their grip in their fingers, and knees. Another thing is velvety or stretchy skin. Dr. Casanova showed a picture of someone with the characteristically stretchy skin, but again, EDS is a spectrum. Not everyone with EDS will have all of these symptoms, but these are just common things that you can keep an eye out for. I was told my entire life, oh my gosh, your skin is so soft. Like do you lotion? No, I was a child. It was just like velvety. People always described it as velvety. And then some of the subtypes also have doughy. So, kids have baby fat. So doughy is not the best way to determine for a child, but you can usually tell if a kid has abnormally soft skin. Easy bruising. Of course, connective tissue plays a role in blood vessels as well, and the skin. And so a lot of people with EDS are very easy bruisers. You see their legs kind of covered and you ask them, how'd you get that bruise? And they're like, couldn't even begin to tell you. Didn't even realize it was there until you said it. And that's especially seen in children because they're playing, they're clumsy, they're running around. So very frequent bruising. And then the one that I think is most important to note is growing pains. I spent most of my childhood up at night crying because of growing pains. That is not apparently what is supposed to happen. So if you have a child who is constantly talking like, oh my gosh, my joints hurt at night, my bones hurt, all this, and it's like really, really frequent and chronic, I would maybe look into seeing a physician, getting that assessed, because 10 years of growing pains every night was not what was supposed to happen, I guess, apparently. You find out after the fact, Most important thing, if you suspect your child to have EDS, talk to a physician. We are not medical doctors, so we can't really help you in that, but we can tell you the things that like I wish I had known as a child. And another thing is getting them into things like physical therapy, occupational therapy proactively are very helpful. Physical therapy to teach them how to protect their joints, like teach them proper posture, teach them to stand without hyperextending their knees. And then like I mentioned, the developmental coordination can often be impaired due to proprioceptive differences. And then OT for things like sensory regulation and fine motor, like holding a pencil, things like that. Starting them early is best instead of trying to play catch up as an adult with physical therapy once the damage is already pretty progressed. And then a problem that I discovered while doing my research for this is there is a huge gap in care and a lack of providers for people who have both autism and EDS, especially for people who present more severely for both conditions. So, a lot of the doctors that I see regularly for my EDS are orthopedists, and, a lot of them don't work regularly with people on the spectrum, especially people with higher support needs, things like that. And so it can be really tricky. It can be hard to feel heard and understood, I should say. And it's just kind of hard when you are someone with higher support needs and a doctor sees almost no patients with support needs like that, as opposed to, the kind of like a developmental pediatrician that is familiar with autism knows how it works. On the other hand, a lot of providers who work extensively with children with autism aren't familiar with EDS. And so you can kind of see this disconnect where they're not understanding the autonomic dysregulation and how that can play into behaviors and emotions and things like that. And also not understanding the physical limitations that can come with EDS. And so, it can kind of be a disconnect, and it can be very disheartening for a child when it feels like either side of the table isn't understanding or listening to them and what their body is telling them. That would be my biggest piece of advice. Listen to your body from an early age. And really that's it. So hopefully, as the connection between EDS and autism is explored further, more providers will become more knowledgeable in how to work with both conditions. Obviously, I'm not saying that a developmental pediatrician should be an orthopedist as well. Familiarity with both conditions could help a lot of people get diagnosed earlier when possible and save a lot of grief that comes from being a child or an adult in pain and not having answers or feeling like you're heard. So that is all that I have. If we want to jump to the Q&A, I just went over that slide, so that's good. So that's all I had. And then I'm happy to answer any questions. Dr. Casanova can probably answer them a lot better, but personal experience ones, I've got a whole lot. So.
Okay, great. Well, we have a lot of questions here today. So I'm going to do one quick thing here. I'm going to have a slide up so everyone has something to look at. So I'm going to leave that up. Okay. And then I will get to the Q&A. So everybody who's here, if you have questions, please type it in the Q&A section. There are quite a few already, so we'll get started on all of those. The very first question that we received here, my older sister has tested positive for HEDS, 52, but without autism. Younger daughter, 47, nonverbal autistic with epilepsy. Would you recommend testing? Where would they go for an adult who might want to get that type of evaluation?
Emily, do you want to answer that one?
Sure. Well, I would just say it's really going to depend on where they're located and what's potentially available. From my personal experience, as well as hearing that from others within the zebra community, which is the Ehlers-Danlos community, I have heard usually the best results on average from geneticists. So if you can find a genetics clinic that is taking hypermobile EDS referrals, that would probably be one of the best places to start. Sadly, that's not a guarantee. Even if there is a genetics clinic near you, there is unfortunately a growing trend for genetics clinics within the US as well as abroad to no longer take hypermobile EDS referrals. And some even like Greenwood Genetics that I'm working with. I was astounded. They don't even take classic EDS referrals now. Which is bizarre because you can still, their justification in part was we're a genetics clinic and we're not finding any genes. So, but unfortunately, they're one of the few that are trained, what we call dysmorphologists, and which means that they're trained to investigate the body. They usually have training in something like the EDS assessment, which I very few other physicians are going to have, at least to that extent. I've also not heard typically great things from rheumatology. I've noticed and I'm not saying all rheumatologists, there's always going to be exceptions. But in general, they theoretically would know how to do this. They would know how to give an EDS assessment, but there is a cultural trend within rheumatology that I hate to say is rather patronizing. And it seems like a trend that they don't like the number of EDS diagnoses that are occurring. So it's not the healthiest cultural environment I've noticed from rheumatology. So if you find a rheumatologist that's an exception to that, that's wonderful. But my first recommendation would be try to go the genetics route. You can do some panels, at least to rule out some of the more common or the more rare forms of EDS. Most people are not going to turn up with anything with those panels. But they at least do have the training to do a physical assessment. So that would be my recommendation. Rosie, what about you? Do you have anything to add to that or anything else?
I was originally told to see a rheumatologist to get a diagnosis. Went to the rheumatologist. She said, I don't do that. I don't. So then I got sent to a geneticist. But I know a lot of the places like UT Southwestern are no longer doing EDS genetic testing. I will say there's some private ones that you can get, but I've seen a lot of people who get false like flags. It kind of says that everyone has vascular EDS, which is very rare. Most people do not. And it's also, I know that I personally, we just thought, oh, I just have HEDS. I just have hypermobile, but we'll do the genetic testing just to be sure. Turns out I have one of the ones that has a gene identified. But I would say for genetic testing, a lot of it, or the more common ones, is kind of just to make sure that you don't have the vascular type, because that requires a lot more care and observation. But with mine, I was able to then get referrals to neurology, cardiology, things like that. So it's valuable if you can get it. It's really hard if you have a history of hypermobile EDS, a lot of doctors will say, we just won't test you. Because they're like, there's no gene identified for HEDS. It'll be a waste of our time. So try and find someone to do a physical eval. If you think that you could have a type that is identified by genetic testing right now, I would push for it. In the EDS community, you often have to be your own biggest advocate. So like I myself thought that the genetic testing would be a waste of time for me because I just assumed I had HEDS. Turns out I didn't, but it's more important to have someone do a physical eval and determine that and then go from there.
Yeah. And there's also other clinics around the country too. Like, I just want to give an example of if you're able to travel, and I don't know if that's an option, but for instance, like right next door from me is Tulane, and there is an EDS clinic that is there. And there are other examples of that too. So I don't know if you're limited to your region or if travel is an option too. With those kind of places, it can take a while to get an assessment, because there's a wait list, but it's worthwhile looking into as well.
Okay, so this person is asking, they signed up for Spark. So, and they also included the link there if anyone wants to check that out. It's the top of the Q&A right now. I signed up for Spark because my daughter is hyperflexible and has a diagnosis of PDD and OS. Will our genetic material help research? I was also diagnosed with autism last year, but I don't have EDS. So Emily, if they wanted to participate in research, can you think of anywhere they should go look?
Well, it just really depends in what manner they want to get involved. I mean, Spark is great. I'll say, I know not everybody is keen on the genetic sides of things, but it is always good to at least rule out. And like I said, I think the better that our research gets, the more able we're going to be able to identify more of these complicated, subtle genetic patterns. Because for a long time, we've kind of been limited on, that's a rare one. Okay, we've identified that. It's occurring in autism, but it's not occurring in the general population. So that's easy. But so the science is slowly catching up, not so much in how we're genotyping people, but in how we're analyzing that data. So I will say it's always important to donate material to something like Spark. Just for hopefully we may eventually get to looking at something like these hereditary connective tissue disorders, which are probably not just limited to the collagen-based Ehlers-Danlos stuff. It's probably, more complicated than that. So I would say that's a great start. I will also say that if you have friends who have kids on the spectrum or family members who are also in a minority population, I will also say, please consider donating, because I'm working with the data right now and I can see there's a dramatic underrepresentation, for instance, of African Americans. There's about 75 compared to over 2,300 in the Caucasian population. But anyways, I digress a little bit there. But I do say that's a great start. I think we're going to start seeing more researchers getting into this area, looking at this overlap between autism and hereditary connective tissue disorders. Ehlers-Danlos is not the only one. Hereditary connective tissue disorders are a broader group that basically have some kind of issue with the connective tissue, and you may see hyperflexibility, but you may see other variations in the presentation. But I would say, keep an eye out on some of the other researchers in the fields that are doing work with these connective tissue disorders. I always usually try to publish if I'm recruiting on my blog. Sometimes there may be an online thing. Other times it may be, you would need to be able to come in. We're working on trying to, especially like with the Fragile X thing, trying to get funding to be able to pay for people to come in, pay for flights, pay for hotels, so it's that sort of thing. And whether you're able to come to the Mine Institute location or the Greenwood or the Loyola Institution, those are always potential options. So but it's been a little bit slow going, unfortunately. But we're slowly getting there. But you're welcome to keep in touch with me and to keep an eye on my blog. Like I said, if I'm recruiting and it's not just from the local area, you're probably going to see something up there from me. So that I would say that's a great start. Spark and keeping an eye out on just some of these, and ARI I'm sure does some occasional advertisements too. So so keeping an eye on some of those websites and some of those individuals' work. It's still early. I wish I had a better answer for that too, though, sadly. So, but also too, if you want to give ARI more money too to help with more research into this, that's awesome. I mean, I'm probably one of the few researchers that's looking into this. For me, sometimes that's great, but then for the stakeholder population, that means there's a severe bottleneck. And so it would be fantastic to get more researchers studying this overlap as well. And so I think also pushing some of the organizing bodies. And, NIH, it's another good one, putting pressure on NIH to try and fund something into this overlap as well. And we talked about Spark too, even talking with Safari, having parents, having family members, even putting pressure on Safari to try and fund these types of studies, because they're the ones that have the Spark data. So, that parents and families have been a really phenomenal means of moving autism research forward and getting additional funding. And, and that's still something that, is feasible. You're still a force to be reckoned with. Right. So, so I would say use it if you can. So.
Hey, so this person was asking about, you had addressed this about traveling for genetic testing, and they asked about a list of options around the country. I'm going to put this in the chat. Another attendee, thank you. It looks like Janae shared a link to the Ehlers-Danlos directory. So I'm going to put that in the chat now. So that's there. If somebody's looking for that, that should help if you're looking regionally. Doesn't guarantee there's one in every state, but there's also, if you look in the Q&A, there are also, I'm not going to read all of these, but people are mentioning some of the centers where they've gone and had personal experiences. So you could look at that and check that out. For Spark, Emily, can you tell them what Spark is?
So I'm not going to go into the acronym because I always forget it, but essentially it's our major autism genome database. It's been going for a while. It also includes some of the older databases as well. So some other stuff that came from Simons. I think also possibly the Agree database may have been shoved into there, but I'm not 100%. But ultimately their goal is to collect 50,000 genomes of individuals who are on the spectrum, as well as family members, especially siblings who are not on the spectrum. It's always great to compare. We're doing that in one of our studies right now, and we're seeing some interesting similarities and differences between those on the spectrum and SIBs. It's a great way to take part in genetics research. There's a variety of different centers around the country that collect that genetic data, the blood samples. And which I know is not always easy to get out of an autistic person, but if that's something that your family member or yourself is willing and able to do, I do highly recommend it. It's highly protected. It's something that researchers have to apply and go through a considerable set of steps for approval. And so it's not something like, oh God, what is 23andMe doing with my data or something like that, right? So this is something that it's restricted specifically for research on autism and related conditions.
Okay, and I just shared the link to that in the chat as well. So if anybody is interested in learning more about Spark, that is there.
Good.
So here's a question totally unrelated to the prior ones. And Emily and Rosie, you may both have thoughts of this. Is stimming seen in EDS without autism for some reason, perhaps as a result of proprioception?
Rosie, you want to cover that one?
I would say yes. Stimming is just a way to kind of calm the nervous system and bring someone back, center them a little bit. And in EDS, you're kind of constantly in the fight or flight zone. And it's a great way that a lot of people use to kind of bring themselves back down, try and calm themselves a little bit. So yeah, it would happen likely because of the sensory differences we talked about, and just the general sympathetic activation that is like constant almost.
Yep. Yeah, it's a great way to try and regulate the sympathetic nervous system. So that's certainly anything that's common across autism, Ehlers-Danlos, ADHD, because you certainly see stimming in ADHD, maybe of a slightly different, type. May not see quite as much hand flapping and rocking and things like that, but you certainly see a lot of stimming in ADHD as well. And again, a lot of sympathetic overactivation in ADHD too. So yeah, it may not always look identical to what you may classically see in autism, especially for younger kids. Like I said, you may not always see the hand flapping, rocking, stimming with water, spinning wheels, things like that. So it will be usually probably more adapted to that person's level of social awareness. And it's also age dependent too, but definitely stimming is common throughout all of those conditions.
Hey, so here's the interesting question. This person says, my daughter was diagnosed with EDS in high school. She's now 25, and it appears that her height has changed. She's shorter. Has anyone experienced this?
Yeah, there are a lot of spine issues that come with EDS, kyphosis, scoliosis, ankylosing spondylitis, things like that, that can contribute to differences in height. Shrinking almost. So I would recommend seeing someone who knows about spines and looking there first, because that would probably be where you could get some answers.
Yeah, same thing. Yeah, see somebody who orthopedist, or somebody who is maybe even neurologist if you're seeing any issues that could be related to spinal compression as well, because you can certainly get autonomic symptoms as a result, or worsening due to spinal compression issues. So you definitely want to keep an eye on that. Yeah, because all the nerves have to run in through there, and you don't want them squished. So that can be a big problem for folks.
Okay, and I know we've touched a lot on genetic testing, so I don't want to belabor it, but this person is asking specifically the best way to find out if I have a permutation. So premutation, sorry.
Yeah. It's getting easier and easier. Thankfully, the tests are getting less expensive too. Last I saw, there was even one where you could even do a saliva test for $200. Now it's you still have to go through a physician, and you probably would still want to go through genetics at that point. And they can order that and also see what your insurance may cover. But that's become much easier, and you can see whether or not you're in the premutation range or not. I will also say that, and this is something I kind of have in the back of my mind that I would like to get to as well in future studies, especially when we're looking at the broader EDS, to see, okay, what percentage of this population might actually be on the Fragile X spectrum. I suspect we're probably also going to be finding people in the low range, which is not really as well studied, but there are some similar clinical issues that are coming up. Now, these people are not probably going to be having kids with Fragile X, because their premutation has shrunk rather than gotten bigger, right? And so they're not really at a risk for having Fragile X kids. But there could be some similar clinical issues. And I kind of suspect we might even be seeing some connective tissue stuff down at the other end, because both, when you get out of that kind of Goldilocks region, that 26 to 32, you're actually starting to slowly decrease the amount of protein that's made by the gene. And so that probably, along with other factors, may have the potential to influence connective tissue. I know there has been a report about causing premature ovarian insufficiency, which you see in the premutation range as well. So I kind of suspect you might be doing some similar things. So I think we're probably going to find eventually that there's a whole Fragile X spectrum that's falling outside of that ideal range. And we're going to see a number of these conditions kind of popping up with it. So So genetics clinic. I can't promise you're going to find a doctor who's willing to listen, but you're always welcome to. We have published a case study on this, so if you want to, print it out and even bring it to him. It's not an experimental study yet. That's what we're working on now, but it is a series of case studies looking at individuals with the premutation who either had a previous diagnosis of hypermobile EDS or were assessed at the time they came into the clinic, and we found, okay, even we know you have a premutation, but you also look Ehlers-Danlos. So you're welcome. You can look up my name as well as the Hagermans, and you should find that case study. If not, look me up and I can send you a copy of it. And not saying every doctor is going to listen to you. It really depends on the doctor, but it could potentially help. I don't know if it would mean you'd have to pay out of pocket or not. It may depend. So, but yeah, I would start with a geneticist on that.
Hey, this person's asking about sleep problems. So my son has a lot of sleep problems, easily mixes up day and night. He's 20 now, but he's awake asleep around the clock, sort of like a baby. It's rough on the whole household. Is there any evidence of overlap with sleep problems specifically to EDS? I know that that's not uncommon with an autism diagnosis, but have you seen anything specifically about those same issues? Maybe if someone only has the EDS diagnosis.
Rosie, you want to handle that one?
Yeah, sleep issues are very common in EDS as well. They can come from a variety of things. A lot of people have primary insomnia that get diagnosed very, very early. There are people who can't sleep because of pain. And there's also just general, autonomic dysregulation can kind of really affect your sleep patterns and your ability to fall asleep and stay asleep. As well, it's also just really hard if your body is constantly in that fight or flight to be able to actually go to sleep. And so, yeah.
All right. Well, thank you. I'm going to do one last question. I think it's a good one to end on, and maybe both of you will want to take this one on. It's asking just about self-advocacy, about how to effectively advocate. You've both successfully navigated some of this. So how do you effectively, without sounding over the top, work with clinicians to get those tests done and learn more about what's actually happening for yourself so that you can effectively address symptoms that you're having?
Rosie?
Emily, do you want to answer first?
Sure. Yeah. So I will say I am on the Ehlers-Danlos spectrum myself. So I'm not just a scientist. I'm a patient as well. Which is how I got to studying this, because I noticed, wow, everybody's talking about autism when I came across this patient community. But I will say I was initially lucky that I had a physician refer me fairly quickly to the genetics clinic here at Greenwood while I was still in South Carolina at the time, and I got in before they stopped accepting referrals for hypermobile EDS. So I will say that part was probably the easiest. That is definitely not the case for all people or even most people, especially, as I said, with that trend for genetics clinics to stop, accepting heads referrals. I probably had more issues with the POTS, with getting the POTS diagnosed, the autonomic disorder, as well as the immune disorder. That honestly just takes doing some research in terms of, and maybe some travel, as well as finding somebody who is very knowledgeable in that area. Sometimes that can be expensive. And it's not always feasible for everybody. There are not many allergists, immunologists who treat mast cell disorders, or I should say knowingly treat mast cell disorders, and really genuinely understand how to diagnose them. It's growing in awareness, but I would say that there's a lot of them who take these early diagnostic criteria far too much to heart and follow it to the letter, which is not always so useful, especially at this stage when the diagnostic criteria are not really set in stone yet. It's still very early. And same thing with the POTS. I initially came across an electrophysiologist. So if you were looking into POTS or something, or orthostatic hypotension, any of these autonomic disorders, you would probably go see a cardiologist, and you might be referred to someone who would be called an electrophysiologist, who is a specialist within cardiology. And the first one I came across wanted to torture me with a tilt table test, to which I asked him, is that going to change how you're treating me? To which he said no. And I said, well, then I said, no, thank you. So, sometimes it's also knowing when to really fight for the precise diagnosis versus fight for a diagnosis that's just going to get you accommodations. So at that time, I accepted just kind of an autonomic disorder NOS diagnosis, and that was enough to get me accommodations at work, which thankfully I'm in a place where they're pretty flexible anyway, so I can kind of make my own accommodations. There are just days where lecturing for 3 times in a day, I really do need to sit down. Any number of things. I've had to advocate for myself in terms of not teaching classes too early, because a lot of times for folks with POTS, mornings are not great. And so it takes time to get the old, nervous system going a little bit. And so I've had to learn to advocate and just say, if you want me to be able to work, this is how I need to be able to do it. Otherwise, my health is really going to start declining, and you're going to get much less work out of me long term. So I've had to advocate that way as well. So those have been my primary experiences. Most of the time, I've just used the medical community to the extent that I needed it, and then have kind of done my own thing. It has helped that I'm a scientist. So even though I'm female, they tend to give me they tend to listen to me a little bit more because I'm using words that they recognize. But that's not a guarantee. So I will still, for instance, bring my husband with me whenever I go to see a new physician, because there's always that potential hysteria bias, even with me as a scientist. So until I know what that physician is going to be like, I do tend to take some of those precautions as well. So
I had a much longer and unfortunate process towards getting diagnosed. My mom was accused of Munchausen by proxy, all of this stuff, which is not too uncommon for people with EDS to get accused of, especially moms. I will say moms are the greatest. My mom, I wouldn't have a diagnosis without her. But even with that, I started having hip issues at the age of 5, and I did not get my first hip surgery till I was 19, second one at 20. And that whole time I was trying to get care. But everyone just said, she's just a girl, she's dramatic, she's a teenager, whatever. So what I would say is, you know your body best. And if you are going to a doctor and you feel like they're not listening, or you feel like they aren't understanding, go to another doctor. You aren't obligated to stay with that doctor. I would also really recommend support groups online. The Ehlers-Danlos Society has support groups you can find. There are things on Facebook, Reddit, things like that. But I would just say, listen to yourself. I know, especially because I started having symptoms before I was even school age. And I was constantly being told, no, you're just being dramatic, or that's not what's happening. I really still struggle to believe myself. So I'll downplay things like, oh, it's not that bad. My heart rate just got to 200, but it could be worse, So for me, I still take my mom to appointments if they're in my hometown. And I still call her directly after every doctor's appointment to tell her I only this year started going to doctor's appointments by myself, and that's mostly out of necessity because I live hours away from home now. But parents of young children, I would say believe your children and fight for them, because no one's going to take an 8-year-old girl seriously when she says that her joints hurt. And just keep fighting for an answer. I know a lot of people who had to go to like 10 different cardiologists to get someone to listen. I had to see probably upwards of 6 different orthos just for my hips before I was told, oh yeah, no, there's a real problem there. Before that, it was just, no, it's snapping hips, teenage girls get that. That was bull. But I think it's really important to find an online community, because a lot of people will post and be like, hey, does anyone have any recommendations for this? And the Ehlers-Danlos Society has a list of providers and things, but sometimes people on Facebook know another person, or they can recommend something that you can get, on Amazon, like specific compression socks that really help, or things like that. And they can give you pointers for that. And especially, I know a lot of parents on support groups ask for help, like, what accommodations should I ask for? How do I ask for them for my child? What was your process going through this? Things like that, which can be really, really helpful to have someone else who's gone through it before you or is going through it now to tell you, this is what I did. And even if they can't give you a firm answer, it's nice to know that you're not alone.